as all of us knows that echocardiography is having definitive role in the cardiac surgery, there is no doubt about that. But when we can use this monitor for the other procedures also, or for the other surgery also, it is having the immense role during those kind of the procedures also. So to see that, I would like to discuss the topic indications of transesophageal echocardiography. What are the contraindications? What are the basic views and imaging techniques? TE laparoscopic surgeries, case scenario, and TE liver surgery. These are I'm going to to patients undergoing high cardiac procedures and with significant cardiac diseases undergoing for non-cardiac surgeries too. The heart and great vessels are probed with ultrasound. At 2000 Hz, the ultrasound is sent in the thoracic cavity, is partially reflected by the cardiac structures, and we get the images. From these reflections, distance, velocity, and density within the chest images are derived. Now, what are the different indications? High-risk patients known as suspected cardiovascular pathologies in hemodynamic compromise. Expected to have intraoperative hemodynamic instability and fluid shifts known as suspected cardiovascular pathology that might result into compromise. Major abdominal or thoracic trauma, patients with hemodynamic instability presenting for emergency surgeries, and patients with emergent thoracic aortic dissection presenting for non-cardiac surgeries. Now, indications intraoperatively, if we look for unexplained persistent hypotension, which is not responding to the traditional or conventional treatment, persistent unexplained hypoxemia, low cardiac output, or heart failure, intraoperative cardiac arrest. Postoperatively, when we are dealing with the hemodynamic instability, myocardial ischemia, substantial or escalating vasopressors are inotrope requirements, and patients requiring major resuscitation. Now, if we look for the clinical applications, it helps us in finding out the ventricular structures and functions, hemodynamic parameters, valvular structures and functions, intracardiac masses, cardiac shunts, pericardiac and cardiac tamponade, aortic atheroma, and anatomy and pathology of the vital organs. Now, contraindications are previous esophagectomy, severe esophageal obstruction, perforation, or hemorrhage, relative esophageal diseases, previous esophageal surgery, previous mediastinal irradiation, or unexplained swallowing difficulty. So, in these kind of the patients, we have to be careful and we should not do the transesophageal echocardiography. If you look for the imaging techniques, it is having M-mode, two-dimensional Doppler technique. Insertion of the TE probe is important, and manipulation of the TE probe. These are the things we have to keep it in our mind, how to deal with it. So look for the basic views. Basic views are going to tell us about the evaluation of the greater vessels, including aortic root and coronary arteries, ascending aorta and pulmonary artery. Now, mid-esophageal or PE views, 4-chamber views, 4-chamber 0-degree view, 5-chamber 0-degree view, 2-chamber 90-degree view, long axis view, short axis views, and bicable views. Transgastric views, short axis, long axis, and deep transgastric view. So these are the 28 basic views which we have to keep it in our mind and deal with it during the intraoperative timings. Now, if we look for the laparoscopic surgeries are the very common surgeries, and general surgeons are quite often performing the laparoscopic surgery. So what are the problems in laparoscopic surgeries? It increases the intra-abdominal pressure, which affects the myocardial pressure volume relationship and causes a shift in the myocardial compliance. Right and left heart pressures become unreliable for monitoring the volume status. And patients with advanced heart disease, depending on TE, is the preferred monitor to achieve and maintain the hemodynamic stability. If you see the picture is showing the carbon dioxide gas embolism in the right pulmonary artery and mid-esophageal ascending aortic view. So you can find out where is the gas is going or the gas embolism is occurring, and which is easy to diagnose with the help of transesophageal echocardiography. Now, if we do the laparoscopic cholecystectomy, the laparoscopic surgeries are associated with 4 potential major changes. They are Treadland-Work position, right reverse Treadland-Work position, creation of the pneumoperitoneum, systemic absorption of the carbon dioxide, and desufflation of the pneumoperitoneum. So, in the present observational study by the Krishna P. Gaurav and Govardhan Dattapuri on transesophageal echocardiographic assessment, they have found out the hemodynamic changes during laparoscopic surgery, and M mode of TE was performed when intra-abdominal pressure was 40 millimeter of mercury, and decrease in MAP, LVOT, VTI, and cardiac output after pneumoperitoneum was seen and when associated with reverse Treadland-Work position. So this is the study which I would like to quote it for the finding out the importance of transesophageal echocardiography. These changes with cardiovascular changes could be monitored with the help of cardiac index measured with the help of TE. So this is also one of the monitoring, advanced monitoring which we can do it. Now, another case I would like to discuss is 52-year-old male patient within the history of hypertension and diabetes came with ulcerative colitis refractory to medical management and came for us for the laparoscopic colectomy. Stress echo, which was negative for ischemia, echo preoperatively, ejection fraction was 58 and mild LVH. Routine general anesthesia with large bore IV was given and a little bit about the laparoscopic colectomy, head low position, abdominal insufflation, minimal blood loss, and during the first 30 minutes. So case early events has occurred on the OT was hypertension following, and hypertension treatment was given phenylephrine and ephedrine. And we have noticed the following changes: heart rate, cardiac index, and blood pressure got disturbed. And TE has shown us the tachycardia and hypertension and RV strain pattern. Now, the more significant changes we have noticed was the arterial desaturation and heart rate went up and SpO2 started falling. So dobutamine was started, but patient has not responded with the dobutamine. Now, TE has shown the right ventricular strain pattern, and again the changes of the heart rate, arterial saturation, arterial desaturation was continuously going on, and cardiac index reduced and SpO2 also reduced. So patient has shown the signs of tachycardia, fall in SpO2, increase in cardiac strain, which shows the right pattern with the help of TE. The following treatment was started: vasopressin, albumin, milrinone, norepinephrine, epinephrine, and soda bicarb, and still the patient was not responded. So even after administration of these drugs in view of hypertension, the persistent right ventricular strain pattern was there, and which persisted was recognized with the help of TE. This helped us in early diagnosis. Recognition helped to place the impeller device in cath lab. So patient was shifted to cath lab and the impeller device was placed in the patient. Little bit about the impeller device. It is a treatment of acute myocardial infarction complicated by cardiogenic shock and the facilitate the high-risk PCI, the treatment of cardiomyopathy with acute decompensation, post-cardiotomy, cardiogenic shock, and off-pump coronary bypass surgery was advised. Now, these are the changes which we have noticed in the ABG. Severe acidosis was there and base deficit was -16. So changes in the heart rate, saturation, desaturation, cardiac index, SpO2, respiratory was noticed. And this is the impeller device was placed in the cath lab. And then patient shifted to general surgery OT for the colectomy. So how we see the right ventricular strain pattern is absent after putting the impeller device and contractility was improved. So this was the clear-cut indication which was diagnosed with the help of TE and patient was taken care of. Now, if you see the TE can help us in the liver surgery also. The TE in detection of the intrapulmonary shunts in patients of liver diseases. Saline through the peripheral vessel and presence of the microbubbles in the left heart chambers 4 to 6 weeks after initial appearance of contrast in the right side of the heart was an indicator of intracardiac shunt. So rescue TE can be done after the procedure. When performing the rescue TE, the evaluate ventricular contractility, ventricular diastolic volume, and presence of the pericardial effusion to direct further examination. No immediate etiology of hemodynamic stability is identified. 16 view exam should be considered, and additional view of extracardiac pathologies should be taken into consideration. Now, rescue team is having the clear-cut indications that patient is stabilized, transesophageal mid-papillary view, patient is stabilized mid-esophageal left axial view, 4 and 5 chamber view, and bicable modified bicable view, extracardiac exam for pulmonary edema, and call for the help in the clinical decision to make it. So full T examination can be done when the hemodynamic stability is there. So I would like to conclude that TE has become the cornerstone in the non-invasive diagnostic evaluation. TE is also used in monitoring of the patients with suspected cardiac diseases or hemodynamic stability. TE is an image-based technology and is best learned through materials, video loops, and regular hands-on training. TE is especially useful to achieve and maintain the hemodynamic stability, laparoscopic surgery, and surgeries such as colectomies, etc. So these are my references. Thank you very much for the patient's hearing. Now I'm stopping my sharing screen, and I have to introduce the second speaker of the today's session. Can I see the slide? Her slide? Yeah. She is Dr. Sanjeeta Umbarkar. She is heading the Department of Cardiac Anesthesia at Sachde Medical College, KM Hospital, Mumbai. She is PG teacher for DM Cardiac Anesthesia, teaching experience more than 25 years, special interest in pediatric cardiac surgery and heart transplantation. And I'm sure that she's working for that, and soon they are going to start the heart transplant at GS Medical College. Various positions held at national and international level. And she's a national faculty. She's PIECTA teacher, fellowship awardee of the Indian College of Anesthesia. And she has many more achievements in her credit. So Dr. Sanjeeta Umbarkar, she is going to speak on the obstetric hemorrhage and role of TE, how the TE can help in these kind of the patients. So over to you, Sanjeeta.
Slides are not moving. Hello.
You share your screen.
Yeah, I have shared. Slides are not moving.
Go to slideshow, and since beginning. Yes, since beginning. Slideshow, go to slideshow.
Just a minute.
Yeah. Yes. And from beginning, yeah.
Yeah. At the outset, I will like to thank Indian College of Anesthesiologists, Dean Dr. Muralidhar Kanchi, Dr. Radhakrishnan sir, Dr. Jiaisha madam, Dr. Baljit Singh, and special thanks to Dr. Manjula Sarkar madam for giving me opportunity to share my views on the role of transesophageal echocardiography in obstetrics. Before going into the details of the TE in obstetric patients, I will like to have some words about the physiological cardiovascular changes of pregnancy. These changes occur to meet the increased metabolic demands of the mother and fetus to ensure the adequate uteroplacental circulation for fetal growth and development. So these changes are like systemic vasodilation, increased vascular compliance, increased cardiac output. And these values are consistently underestimated by transthoracic echocardiography. Again, the slide is not moving. Hello?
On the left side, these arrows are there, see. 2 arrows are there.
Yeah, from there again.
From there.
Okay, fine, thank you. So the cardiac remodeling also happens where there is increase in LV as well as the left ventricle as well as right ventricular mass. And these physiological changes, they become prominent and the obstetric patient, they become unable to tolerate this, to adopt these physiological changes of pregnancy, and they expose this underlying or previously silent cardiac condition into the prominent. So in this figure, you can see how the chamber dilatation and various vascular diameters, they increase in obstetric. Why there is rise in pregnant patient, the cardiac patient? Because there are advances are happening in surgical repair. So there is increasing number of female patients coming with the congenital heart diseases reaching the childbearing stage. Also, there is increase in the prevalence of cardiovascular risk factors, acquired cardiovascular diseases like diabetes, hypertension, obesity. So the cardio-obstetric has emerged as a important multidisciplinary field where it consists of cardiologists, gynecologists, the obstetrician, then the anesthesiologist, geneticists, pharmacists, and nurse. So, dealing with the cardiovascular imaging in pregnancy, there are risks and benefits. So, what are the risks to the mother if you don't use this cardiovascular imaging? The mother is at risk. If you use various cardiovascular imaging, then the fetus might be at the risk of developing teratogenicity because of radiation exposure. So, hence the transthoracic echocardiography is the first line of imaging modality in assessing pregnant women, and it is safe and has no adverse effects on the fetus. However, this imaging quality depends on acoustic windows, and that may be optimal in pregnancy as the heart is suppressed with the abdomen and the position of the heart is more horizontal. So transesophageal echocardiography is useful too, and which allows a more detailed examination, but it is little more invasive. But still, this T is indicated in diagnosis of endocarditis, mechanical valve thrombosis, and complex congenital heart diseases. You can see in this chart there are various imaging modalities. However, the transesophageal echocardiography is the one which is the safest and doable. So we can say that transesophageal echocardiography is a semi-invasive, portable, safe, readily available, which can provide the real-time unique clinical information. There are many evidence-based, or the literature is available where it has shown that it is helpful in pregnant patients with diagnostic cardiac dilemmas and undergoing obstetric as well as cardiac procedures. This is a landmark paper by the Marcus et al., where they have shown that the use of transesophageal echocardiography in pregnant patient is relatively safe. However, there are certain sudden changes may occur in the intra-abdominal pressure, which may be expected during examination, and they may require sedation. It can be used as a fetal monitor. So, though it is good to use, its utility is good, but one has to remember while using this transesophageal echocardiography that pregnancy-induced anatomic changes, they may occur in the form of swelling of oropharyngeal tissues. There is decreased caliber of glottic opening, increased risk of aspiration, and sometimes you may get a possible difficult airway. Hence, the sedation as much as possible should be avoided, especially benzodiazepines. It can be done with the topical anesthesia with lignocaine. And if at all you want to use, then the fentanyl is a better choice. So these are the indications where the T is useful, like cardiac diseases and obstetric conditions. Whereas cardiac diseases like congenital heart diseases, rheumatic heart diseases, and thromboembolic events, because of those they have occurred, or presence of pulmonary hypertension which is present, then the T is useful. And obstetric conditions like cardiomyopathies, myocarditis, then detection of amniotic fluid embolism in patients with preeclampsia and eclampsia to assess the cardiac status, to identify the risk for the recurrent eclampsia or preeclampsia. So here is the algorithm. You can see that it was advised by the American Society of Regional Anesthesiologists. They have said if the patient with the cardiac arrest is coming, so that patient has to consult the obstetric anesthesiologist at the age or gestation of 18 to 20 weeks. If she is in the low risk, she can be reconsulted or referred back at the gestation of 28 weeks. However, if she is a high risk at that particular point, so she should be consulted to the cardiac surgery and cardiac anesthesiologist. And once then they will take a call. However, if the patient is at low risk at 18 to 20 weeks, then she can, if she becomes a moderate or high risk, then the cesarean section or the evacuation, the termination of pregnancy is advisable that time in a cardiac operation theater. So coming to the most common disease of pregnancy is the valvular heart disease. That too, the mitral stenosis is very common, and it is an independent risk factor for the fetal outcomes. And here, with the mitral valve disease, the regurgitant lesions are better tolerated than the stenotic lesion. Hence, this TE is useful than the transthoracic echocardiography in terms of it eliminates bioventricular function, and you can tailor the fluid management in the perioperative period. Then you can get the if there is ongoing development of ischemia, you will tell the anesthesia management or the choosing anesthesia technique if there is a worsening mitral regurgitation, and also evaluation of the prosthetic walls. So nowadays, use of 3D with the in-face views, it is more helpful. So this T is also helpful during the percutaneous mitral balloon valvuloplasty. So the T procedure to evaluate the presence of atrial thrombus, or if any significant mitral regurgitation is there, that can also be diagnosed. And during procedure, it can assist for the catheter position, septal puncture, and various things. Why? Because why it should be used? Because use of TE during this procedure results in short procedure time, hence the fluoroscopic time is reduced and the teratogenic effects are less. So way back in 1990, in a Journal of Echocardiography, they have said that the transesophageal echocardiography should be an integral part of balloon mitral valvuloplasty. Then coming to the use of TE in critical cardiac surgeries during pregnancy. And it is very useful that everyone knows that when there is a complex cardiac operations become necessary during pregnancy, and timing is crucial for the survival of fetus. And during that timing, if it is used, then it is helpful for mother as well as for the fetus. If the patient, a pregnant patient with the prosthetic wall is coming for cesarean section, there is a article which is published in 2000 in American Journal of Cardiology. They say that along with the cinefluoroscopy, transthoracic echocardiography, there is a role of transesophageal echocardiography in these patients with the prosthetic heart walls to know the thrombosis of the wall. There is one case report. They have said that there was one patient, 27-year-old, who has undergone the aortic wall replacement, and she had come for the now. So the TE was she had undergone the aortic wall replacement and ventricular septal back 15 years back, and now the thrombosis is developed. Now she is coming for the cardiac surgery. So they put the TE, with the TE in the deep transgastric view, they rotated until they get the placenta, and then they saw that there was an umbilical artery flow was there using Doppler, and they could calculate the fetal heart rate. One more, they have not stopped in the literature. If you see the literature, they have said that there are fetal transesophageal echocardioprobes also. So to the percutaneous fetoscopic intraesophageal deployment of the ultrasound catheter was achieved with using this fetoscope. How the T can be used as a tool for hemodynamic monitoring in a high-risk obstetric patient. So this patient was come with the IUFD. So the patient was taken for dilatation and evacuation under sedation. But in between the procedure, patient became hemodynamically compromised. So the T was put, and they found that the right atrial mass was there, and the patient showed the signs of right ventricular failure. So immediately the cardiothoracic surgeon was consulted, and this was removed under using CP bypass, and the patient could be saved. T is also can be helpful to detect the amniotic fluid embolism, where the patient goes into the cor pulmonale, the severe pulmonary vasoconstriction occurs. So that can be removed under CP bypass. So T can be helpful. In one more case report, they have said that the massive amniotic fluid embolism, the T was helpful as an emergency tool to diagnose. Coming to the congenital heart disease in a pregnant patient, he can be needed for monitoring the ventricular function, wall function, then the measurement of pulmonary pressure, quantification of disease and severity. The low risk regions are like AZ, VSD, and PDA. Intermediate etiology of failure, coagulation of aorta, Epstein anomaly, arterial cyst, Penton operation, and Eisenmenger syndrome. We will discuss few of them. In septal heart defects, especially everyone knows ASD, VSD we should use, but if there is a PFO, so attention should be given to the close, it or not to avoid cryptogenic stroke. In this matter, the T is very useful. Here, Amarpreet Gill and al. They have used the transesophageal echocardiography for the monitoring during cesarean session in a patients with complete atrioventricular canal defect, and they have said that it is very useful to understand and manage the hemodynamic variation during cesarean section in parturients with the complex cardiac lesion. One more case report where the
Review literature, just try to conclude the clinical. Review literature is not needed.
So this is the literature is I'm telling because I want to convince people that you should use T in this obstetric patient, how it is useful. People have used. So in tetralogy failure also to see the vascular resistance, the pulmonary vascular resistance, also the systemic vascular resistance, and accordingly you should tailor your anesthesia as well as hemodynamic management. In Eisenmenger syndrome also, especially in VSD patient, it should be used to know the cardiac grid of the patient. In cardiomyopathy patient, peripartum cardiomyopathy patient, there the patient, they have a low cardiac, the low ejection fraction. So that time this T is very useful. In dilated cardiomyopathy, it is useful in guiding the intraoperative hemodynamics and anesthesia management, and also assisted delivery or during cesarean section in the postpartum period. In the cases of hypertrophic cardiomyopathy, it is helpful to detect it or the differentiate it between the hypertensive cardiomyopathy and hypertrophic cardiomyopathy. So the management is can be done of this kind of patient. In patients with eclampsia and preeclampsia, by knowing the stroke volume and the higher E by E prime ratio, you can diagnose these cases, and you can then diagnose whether these patients are having a diastolic dysfunction or no. And if this diastolic dysfunction remains in the after the pregnancy, then this patient is prone for the risk of recurrent preeclampsia. So this is how this T is useful. To conclude, I will say that T is found to be safe and well tolerated by majority of the pregnant patient in the first, second, and third trimester of pregnancy. There is no evidence of adverse effect to the fetus, so noted during T and as a determined by the fetal heart monitoring. Although there are no complications to the fetus as a result of use of like midazolam, like sedatives, but caution must be taken as there are anatomical changes occur in the airway in pregnant patient. It is useful to diagnose many conditions of the cardiac disease when it is in dilemma. It is paramount that the physicians consider the potential benefits and risks their skill in performing TE before they use this procedure in the pregnant patient. Thank you. I like to thank Dr. Sanish also for the coordinating in a fantastic way so that we could do this. Now we're coming to the second speaker, Dr. Rudranil Nandi. He is going to talk on the use of tea in onco patients. Dr. Rudranil is a consultant at in the Department of Onco Anesthesia at Tata Medical Center, Kolkatta. He is one of the editors of a complete guide to onco anesthesia, critical care, and pain. He has credit multiple written multiple chapters and had many publications. He's having special interest in hemodynamic monitoring, thoracic anesthesia, difficult airway, and cancer pain. Over to you, Dr. Nagre.
Thank you, ma'am, for your kind words. Am I audible, ma'am?
Audible.
Okay, so now we'll discuss about the use of transesophageal echocardiography in oncosurgery. So before going into the transesophageal echocardiography, what is the main basic difference between the transthoracic and the transesophageal echocardiography is that during the transthoracic echocardiography, if there is a surgery, the surgical site overlaps with the site of the placement of the standard ultrasound probe. So during intraoperative period, we have to see, if we want to see the heart, then we have to get in different window, and for that transesophageal echocardiography came. And in this view, we pass a probe through the esophagus into the posterior part of the heart, and unlike TTE, here we can see the heart from the back side and almost 1 to 2 millimeter posterior to the heart, and definitely as it is very closer to the heart, so it gives a very good quality image also. So it has already been discussed, but I'm just recapitulating it, that this TE probe, we can antiflex the probe, so that means flexion in the anteriorly and retroflex it. We can also flex this probe laterally, and we have an electronic rotation by which this ultrasound waves we can rotate in different directions. So basically we can position this TE probe in 4 places: upper esophageal, mid esophageal, transgastric, and deep transgastric. So when we are doing transthoracic echocardiography for point of care ultrasound, basically we see the 4 views, that is apical 4-chamber view, keeping the probe at the apex, parasternal long axis view, keeping at the second or third intercostal spaces, and then parasternal short axis view, rotating the probe pointer to the left shoulder, and subcostal view, that is for the inferior vena cava. These 4 views are we can see in TEE or TEE also, but here we can see the heart in a different directions because the probe is at the posterior part of the heart. So mid esophageal 4-chamber, here we can see right atrium, left atrium, just closer to the probe, and here in apical 4-chamber, right ventricle and left ventricle usually we see closer to the probe. So just like for these 4 view I am taking because during an intraoperative transesophageal echocardiography, doing all 28 views or 16 views of an transesophageal echocardiography becomes difficult. So these 4 views we usually do to assess patients' different hemodynamic status, and other things during oncosurgery. So these are the basically TE views. Out of these views during oncosurgery, if there is an hemodynamic instability and we want to see what is the cause of that shock, then we usually do this. We usually see these views: mid-esophageal bicaval, mid-esophageal right ventricular inflow-outflow view, mid-esophageal 4-chamber view, mid-esophageal 2-chamber view, and the transgastric mid-papillary short axis view. So I'm just going into a little bit into the views that we are doing mid-esophageal 4-chamber view to see if there is any atrial septal defect, if there is any dilatation or hypertrophy of the cardiac chambers, if the patient is having any regional wall motion abnormality. Also, we can see mitral valve and the tricuspid valve in this view. And most important utility of this view is detection of intracardiac air, if there is during the intraoperative period. The second view is the mid-esophageal 2-chamber view. Here we basically see the left side of the heart, the left atrium and the left ventricle. And if there is any problem with the contractility or systolic dysfunction or any pathology, we can see it through it. We can see those through it. Now the next view is the mid-esophageal right ventricular inflow-outflow tract view. That is basically, this is the Mercedes-Benz side, and right atrium, left atrium, pulmonary vein and the right ventricle all are encircling through it. And this view is very important to diagnose the pulmonary embolism. So whenever we are suspecting pulmonary embolism, to get this view is very important. Mid-esophageal bicaval view, it is a very important view as far as the oncosurgery is concerned, because in this view we can see the right, we can see both the right and the left atrium, and in right atrium both superior vena cava and inferior vena cava enters into right atrium, and this entry point of SBC and IBC has different importance. The entry point of SBC to RA is important because by this, if we can see it, we can guide our tip of the IJV catheter in this place to record the CVP accurately. And the importance of the entry or the junction between the IVC and the RA is that this point we usually see to measure the IVC diameter or the delta IVC diameter, that is the variation of the IVC diameter, to know the volume status of the patient. And lastly, the transgastric short axis view. Here we can see the papillary muscles, the left ventricular musculature. If there is any left ventricular regional wall motion abnormality, any hypertrophy, even if there is any pericardial effusion, we can see through this view. Now, I'm going into the oncosurgery. Before that, why this T is important in non-cardiac surgery? So it is used for almost 2 decades, and basically with the TE in non-cardiac surgery or oncosurgery, we just want to diagnose the cause of an hemodynamic instability. It can be myocardial infarction, it can be pulmonary embolism, it can be cardiac tamponade, it can be hypovolemia. Because if we can diagnose the cause, the treatment of every single situation is different, and if we treat empirically, the treatment may actually worsen the scenario if our provisional diagnosis is wrong. And for the last 2 decades in orthopedic and neurosurgery, the TE is being used, but now in oncosurgery it is also being used. So why in oncosurgery TE is important? Because in oncosurgery we usually encounter a long duration surgery. If the surgery is CRS hypec, it is usually lasts for 10 to 12 hours. Usually this surgery has a huge tissue dissection, which ultimately leads to huge blood loss and excessive tissue handling, leading to greater fluid sequestrations and maintaining the volume status of these patients becomes very difficult. Sometimes these patients may become hypovolemic. Sometimes if we misdiagnose the hypovolemia, then we can land upon giving more fluid, and fluid overload may happen. These oncosurgery patients often gets neoadjuvant chemotherapy. That means that patients got chemotherapy and then coming into surgery. So these patients may have chemotherapy-induced cardiomyopathy. Cancer itself is a prothrombotic state. So prothrombotic states, that means these often we get many CA patients with pulmonary embolism. In renal cell carcinoma patients with IVC thrombus, IVC thrombectomy, these are very common in cancer population. Besides this, we are dealing with a low hemoglobin, sometimes geriatric, frail, sick patients. So in these patients, hemodynamic instability is very common. And more importantly, that is the most important indications of TE is the goal-directed fluid therapy in oncosurgery. Now, how to do this goal-directed therapy in oncosurgery patient? Usually, we see the bicaval view and see where the right SBC is, and we see the in IBC diameter variations with the respiration. Usually, with inspiration, the IBC diameter increases in a mechanically ventilated patient, and with expiration, the diameter becomes less. So, if IBC size is basically it's an indicator of volume status, but whether any hypotension will be responsive to fluid therapy or not, that depends upon the respiratory variation. And this respiratory variation we can measure it by Caval index or delta IVCD. That is the maximum in IVC diameter, which is usually occurs during the inspiration, minus in IVC diameter during the expiration, where usually we get a lesser IVC diameter divided by the minimal IVC diameter. So if this variation, IVC diameter variation is more than 12%, then usually we expect that this hypotension will respond if we give some fluid. And to see this value accurate, we have to give a tidal volume of minimum 8 ml per kg. Now, what are the other parameters besides this inferior vena cava diameter variations? We can, if we see, there is an approximation of both the papillary muscle, that is called the kissing papillary sign. So that is the signs of a severe hypovolemia. Say we can see it through an transgastric short axis view. If we see that the papillary muscles are almost touching each other, so probably the patient is hypovolemic. Also, we can measure the left ventricular end diastolic area. If it is less than 10%, probability the patient is hypovolemic. If it is more than 20%, probably the patient is in volume overload. So by this thing we can diagnose this. And one more important thing is the pulmonary embolism, which is very common in cancer patients. So ideally in TE, we cannot directly visualize the pulmonary embolism, but we can see the evidence of right ventricular dysfunction, that is right ventricular dilatation, right ventricular regional wall motion abnormality, tricuspid regurgitation, and the leftward intra-arterial septal bowing. So if these things happen, and we can see in our TE finding, then we can probably think of a pulmonary embolism. Now, one more important thing is the T in renal cell carcinoma patient. The renal cell carcinoma patients are very prone to develop thrombus formation, and almost 4 to 10% patients develop thrombus in the renal vein, and which may enter into the IVC and ultimately reaching up to the right atrium. And the operative mortality is very high in these patients, and it can be up to 9.3% if the IVC extension is there. But the most important part is if we can treat it, if we can remove this intravenous thrombus, then the patients has a very good survival. That means 29% 1 year survival becomes 40 to 60%. So here in this group of patients, TE helps a lot, especially in the group of patients where level 3, level 4 renal vein thrombus or IVC thrombus were there. In those patients, the transesophageal echocardiography basically helps in many ways. It helps. It gives us the most up-to-date thrombus level. It gives us whether this patient is a level 3, level 4 renal IVC thrombus. If that is true, whether the patient's main need of a cardiopulmonary bypass, if it is required, then multidisciplinary team needs to be involved, and TE can guide that before that happen. Thrombus extraction under TE guidance is a common practice now. If we use TEE in intraoperative period, we can sometimes avoid CPB also. Location of the vascular clamp or the vascular clamp placement just ahead, just proximal to the thrombus, that can be dictated by transesophageal echocardiography. Transesophageal during the thrombectomy, often we cross clamp IVC. If there is a cross clamping of IVC, that may lead to significant decrease in cardiac output. In those cases, in that time, the cause of that hypotension can be judged by the TEE. Besides this, when that thrombectomy is done, there is a huge chance of air embolism. So that also TE helps. TE helps in diagnosing that also. And lastly, the TE also ensures or the confirms that whether this tumor complete resection was done or not. Now I'll go into another type of oncosurgery, that is the CRS HIPEC, cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. This is usually done for CA ovary patients, and it has a two phase. One is the CRS phase and the second is the HIPEC phase. In CRS phase, there is a huge tissue dissection, and in the HIPEC phase, as the hyperthermic fluid is given, there is almost 3 to 4 degree temperature changes, which ultimately leading to fluid sequestration, third spacing of the fluid, metabolic changes, and everything. So in this group of patients, detecting whether the patient is hypovolemic or hypervolemic is very important, because it is a double-edged sword. If the patient becomes hypovolemic, we will encounter renal failure, sepsis, and all those problems. If the patients become hyper okay. Okay, yeah, and if the patient is hypervolemic, then probably we will have an edema and all those things. So lastly, I am telling you this article where they have done a clinical trial between goal-directed fluid therapy using TEE versus stroke volume variation, that is advanced cardiac output monitor. And in this group, they have compared delta VCT guided fluid therapy with the SVB guided fluid therapy, and they have found that the delta VCT guided fluid therapy is also same efficacious. And lastly, TE guided fluid therapy in major surgery, if delta IVCD is less than 12, fluid should be given at 100 ml per hour. Delta IVCD is 12 to 18, 250 ml per hour. If it is more than 18, 250 ml colloid bolus. So the take home message is, usually TE is used as a point of care cardiac assessment. It has beneficial role in major surgeries to guide fluid therapy, as a rescue assessment tool in hemodynamic instability, and malignancy being a prothrombotic state from IVC thrombus to pulmonary embolism. TE help in managing all those scenarios. Thank you.
You
I can't see the slide, ma'am, actually now.
You are sharing your screen. Share screen.
I have stopped this. I have stopped my sharing.
Okay, fine. Who is the next speaker? Who is the next?
Probably our next speaker is Neeti Makhija, ma'am. So I can introduce you.
Yes. I'm to be.
Please share your screen and show your first slide.
Should I share my screen?
After you and try to finish our lecture by time, please.
So I don't have that. Yeah, please welcome Dr. Neeti Makhija. She is professor in Department of Cardiac Anesthesia and Critical Care in All India Institute of Medical Science, New Delhi.
I will be, good evening. I will be talking on role of TE in trauma and orthopedic surgery. Trauma is by large an emergency situation, and patient may often present with shock and maybe with or without visible injuries, and maybe requiring mechanical ventilation, and time does not permit us to undergo elaborate investigations, and patient may have to be resuscitated side by side, taken up for urgent surgery, and wherein comes the role of echocardiography. So transthoracic echocardiography is the first imaging modality. It is a non-invasive test, but it's suboptimal in cases of obesity, overlying bandages or chest tubes in a trauma patient, and also the effects of positive pressure ventilation that may make evaluation difficult. Transesophageal echocardiography is a readily available and a portable in operating room, and it can be performed even during resuscitation and without stopping any surgery. And image quality is very good, excellent, and it has got a greater sensitivity and specificity in the evaluation of many pathologies. At the very outset, to highlight the role of transesophageal echocardiography in trauma and orthopedic surgery, I would like to discuss a case published. 28-year-old female with morbid obesity and type 2 diabetes mellitus with a history of recent unrelated knee injury. She presented with loss of consciousness following motor vehicle crash, and her vitals were normal, and 100% saturation and X-ray chest was normal. And she had a fracture of bilateral nasal bones as well as transverse process at L2 level, and left clavicle, fibular neck, and ankle were also fractured. And she was scheduled for open reduction and internal fixation. So under regional and general anesthesia combined. So prior to prepping during manipulation of the knee, she had sudden onset of hypoxia. The saturation had fallen to 71, hypotension, tachycardia, and her EtCO2 had fallen to 12 from 39. And a manual ventilation, she was taken into manual ventilation, which showed a good compliance, and her airways were clear on fiber optic bronchoscopy, and X-ray chest was normal, no pneumothorax, and she was administered epinephrine. Then TEE was performed, and on TEE, her right ventricle was dilated, and that showed there was severe RV dysfunction that and sparing of the RV apex. As you can see, normally the RV is only around 2/3 of the LV, but here the RV was nearly equal. And then there was a PFO present with the right to left shunting, as well as there was an embolus seen in the occluding her right pulmonary artery, both in the long and the short axis views. And however, the LV was normal. So based on the investigation on the TEE, a catheter-directed injection of tissue plasminogen activator and was given, and thrombectomy was done, and she was scheduled for open reduction and internal fixation at a later date, and patient was saved. So that is how the TEE helped in this particular case as a rescue investigation. Coming on to the indications, as classified by American Society of Echocardiography and the Society of Cardiovascular Anesthesiology, they have been categorized into three categories. Category 1 with highest level of evidence, which help in changing the management in around 80% of the cases, with helpful in rescue TEE for diagnostic evaluation of life-threatening disturbance unresponsive to treatment. Basically, this is done to assess ventricular functions, global, regional, LV or RV dysfunction, or to rule out any pericardial tamponade or hemoperitoneum, and help in various pericardial window procedures, or to detect hypovolemia, suspected valve pathology, suspected aortic pathology like dissection, rupture, aneurysm. Coming on to the class 2 indications, a category 2 that may be useful in improving outcome, that is at risk of ischemia or myocardial infarction, at risk of hemodynamic disturbance or detection of air embolism or a foreign body, or a suspected, or in cases of suspected cardiac trauma in the evaluation of pericardial effusion. And category 3 they included evaluation of thoracic trauma and for the post repair of thoracic aortic injury and in orthopedic surgery. So coming on to the various assessment that one has to do during when the patient crashes in a rescue. Echocardiography is TE for hypovolemia. Dr. Nandi has very well elaborated about it, so I need not go in so much of detail. It's basically, as you can see above, it's a normal contraction, and here you can see the papillary muscles are approximating to each other. And here the hyperdynamic heart, there will be increase in the ejection fraction and the fractional area change, and a decrease in the left ventricular and diastolic area. And the management is basically volume administration. So in the LV systolic dysfunction, PEE can help to detect any focal or global dysfunction for the detection of regional wall motion abnormality or any decrease in ejection fraction, fractional area change, or fractional shortening can be viewed. LV may be dilated, or there may be a spontaneous echo contrast as seen in this particular video. There may be even thrombus or LV aneurysm, and this is basically managed by optimizing oxygen delivery, heart rate, rhythm, inotropes, and intra-aortic balloon pump, and afterload reduction. So coming on to the RV systolic dysfunction, again can be seen by focal or global decrease in the function, wall motion abnormality or RV dilatation. Above is a normal RV. You can see the relation of the two ventricles, and this is a grossly dilated RV, more than the size of the LV can be appreciated just by seeing. And here again, septal diastolic septal distortion is there. If there's a video, I could have shown you. And then there may be a tricuspid regurgitation. And this again is managed by optimizing oxygen delivery, heart rate, rhythm, inotropes, and also the treatment of the underlying cause. Coming on to the assessment of the diastolic dysfunction. Here, diastolic dysfunction is graded as normal or impaired or pseudo-normal or irreversible based on Doppler parameters like mitral inflow velocity, the pulmonary venous inflow velocity, the tissue Doppler imaging of the mitral annulus, and accordingly managed. Then there can be a tamponade with a collection of fluid. It can be a pericardial effusion, and if it is a greater amounts, it can result in tamponade with a RV or LV diastolic collapse, as seen in the above. This is a systolic collapse of the atria, and then the diastolic RV collapse can be appreciated. Then there is increased tricuspid E velocity during inspiration, and mitral E velocity is decreased during inspiration. And then the paradoxical movement of the septum is towards the RV can be appreciated during systole. And IVC is dilated, and hepatic venous flow reversal can be appreciated during expiration. And it can be managed, thus managed with pericardiocentesis. Then pulmonary embolism, I've already talked about in the case there, as Dr. Nandi has also said, embolus may or may not be present. Like it may be present around in 25 to say 35% of the cases, and other indirect signs are positive, are seen. Like McConnell sign, that is severe RV dysfunction at the base with normal wall motion at apex, RV dilatation, tricuspid regurgitation, flattened interventricular septum, pulmonary artery hypertensive changes or pulmonary artery or IVC dilatation, again managed with anticoagulation, IVC filter, thrombectomy, and supportive care. Then there is an entity of hypertrophic obstructive cardiomyopathy, that is LVOT Obstruction can be there. This is a entity, this is an entity associated with the thickened interventricular septum, which may lead to systolic anterior motion of the mitral valve and may result in a hypotension, may result in collapse. Collapse or hypotension may occur in case where there is hypovolemia. And these patients are typically treated, managed with volume administration, reduction in inotropes in these cases. Avoiding tachycardia, beta blockers, and maintenance of the afterload. See, if we don't have a TE, we may go on accelerating on the inotropes, which will be deleterious in such a situation. Then blunt and open chest trauma cases in these patients. In patients of there may be suspected contusion or ischemia or stunning may be present, or LV wall motion abnormality may be present in cases of blunt trauma of chest, or sometimes traumatic valvular injury may be demonstrated, like laceration of the valvular annuli or a rupture of chordae, or a direct cardiac injury can occur that can result in pericardial effusion or a tamponade. Then blunt aortic injury can also be occur, and these aortic ruptures are usually following automobile accident, are usually fatal most of the time. Retrospective study have demonstrated only 2% survival. Survival is very less. Usually patient die on the spot, but few patients who survive. I happen to be lucky to manage a case of an automobile accident with an aortic rupture. And once the patient could be brought to the hospital, we could save the patient. So here, with the help of a TE, direct dissection or a intimal flap can be seen, or a thrombus or a debris or a tear can be appreciated. The wall may be thickened because of a hematoma may be there, and then there may be associated cardiac contusion, or a rupture valve or a pericardial effusion can also accompany. So typically the site of injury is at the junction of the arch is a mobile structure and the descending aorta is relatively tethered. So at the junction, at the isthmus, the injury is quite common and will be a dissection flap can be seen. So again, this will be now managed with beta blockers, alpha receptor, and then ultimately have to be managed by endovascular or open repair of the aorta. Then penetrating injuries can be there, like traumatic aortic fistula or a ventricular laceration or a nail gun wound. Above, you can appreciate a knife wound through the interventricular septum. And here, a nail via RV into the aorta, you can appreciate in this image. So with TE, an exact anatomic location can be isolated and rapidly managed, and also post-repair assessment can be done. In the case of burn, severe burn injury, that is a unique challenge in resuscitation, and the severe burn may present with usually hypovolemia or systolic or diastolic dysfunction, infection, sepsis, or infective endocarditis may be there, and sometimes there may be overtransfusion leading to fluid overload. So these patients are often managed by the critical care physicians by HDEE, that is hemodynamic ultrasound, with which hemodynamic monitoring can be done up to 72 hours. So it is very essential in the case of burn injuries to outweigh risk and benefit, as there may be thermal burns of the mouth or the pharynx, which can be rather more harmful than beneficial. So there have, like in critical care, there has been no protocol, but recently in 2022, Viron Arango et al. Have suggested a protocol of assessment in a patient of trauma, wherein they have suggested mid-esophageal 4-chamber view, mid-esophageal long axis view, a transgastric short axis view, a mid-esophageal bicaval view as a basic views for assessment. In addition, descending and ascending aorta long and short axis views, plus the basic Doppler applications are to be done. Coming on to the orthopedic surgery and the bone cement implantation syndrome. Bone cement implantation syndrome, it occurs due to cemented processes. That is, there occurs release of methacrylate, cement monomer, and other sources. It may combine with other sources of emboli like air, bone marrow, fatty particles, and fibrin aggregates. And patient may present with a transient desaturation, hypotension, cardiac dysarrhythmias, cardiovascular collapse, and even death may occur in 0.6 to 1% of the cases. So here the TE helps in the assessment of hemodynamics and diagnosis and management of a bone cement implantation syndrome. The thrombotic material embolus that passes into the right heart chambers basically, and that can be visualized. Here again, the TE findings are similar to the pulmonary embolism I have previously discussed. So TE helps in the evaluation of even ventricular function during CPR also, and it is useful for the volume assessment also. Coming on to the contraindication, absolute is being esophageal pathology or trauma. That is most important in the case of trauma. The trauma involving esophagus or upper GIT has to be seriously considered. Then of course, these recent GI surgery or perforated viscous, that's maybe due to trauma, or full stomach in unprotected airway. The relative indications are also listed. They have already been discussed by Dr. Manjula. And then there can be complication, dinophagia, upper GIT hemorrhage, esophageal perforation, dental injury, and endotracheal tube malposition. And to conclude, TEE is valuable tool for perioperative management of acutely injured patient, to address hypotension, to guide resuscitation, to diagnose hidden chest injuries, and to manage the patient. And it can be done bedside or during surgery. It provides better imaging in mechanically ventilated patients compared to transthoracic echocardiography. It can be interpreted by clinicians themselves. And it is, however, operator dependent and requires formal. So the anesthetist and the intensivist managing trauma should receive basic TEE training. And implementation of hands-on training into focused educational program can allow early introduction of TEE to the residents, and of course, use of simulation in TEE training of simulated cardiac arrest has been reported in the literature with considerable accuracy. Thank you. So I unshare my screen.
Please share the screen. Unshare your screen.
How to stop share? Okay, I got it.
I introduce next speaker.
Hello. Shall I start my talk?
Yes, I am really delighted to invite Dr. Jiaisha Sachde, who is the professor in cardiac anesthesia at UN Mehta Institute of Cardiology and Research Center in Ahmedabad. Dr. Jiaisha is a extremely experienced anesthesiologist and has great interest in echocardiography, especially transesophageal. I request her to do the presentation on the role of echocardiography in organ transplantation. Dr. Jiaisha, please start your talk.
Thank you very much, sir, for kind introduction. I'm going to speak about role of TEE in the organ transplant surgery. TEE is a minimally invasive monitoring tool that can provide real-time visual information on ventricular function and the hemodynamic volume status in patients undergoing organ transplantation. Two-dimensional and the Doppler imaging TEE complements other monitoring modalities like the invasive arterial monitoring and flow-directed pulmonary artery catheterization, and provide the information which are not obtained by other means. Next. Patient undergoing major organ transplantation, heart, lung, and liver have undergoing cardiopulmonary dysfunction that is severely challenged during and is amenable to evaluation by the intraoperative T. Here we focus on the T during the lung and liver transplantation. Next. Role of T in orthotopic liver transplantation. Next. Routine use of the T 40 to 72% in the high volume liver transplant centers. American Association for the Study of Liver Disease states that T should be used in all liver transplant candidates in order to assess chamber size, hypertrophy, systolic and diastolic function, valvular function, and left ventricular outflow tract obstruction. T is a tool as cardiovascular monitoring, evaluate the lungs and pleural spaces, assess the hepatic vein blood flow and inferior vena cava anastomosis and the patency. Next. Indications for the T in liver transplant patient are monitor the cardiac function, intravascular volume status, assess the inferior vena cava patency when stricture of the suprahepatic inferior vena cava anastomosis suspected, and hepatic vein and the IVC thrombus, which can lead to the allograft congestion and the hemodynamic instability. Next. Basic intraoperative T during the orthotopic liver transplant are real-time information on the left ventricular size and function, valvular anatomy and function, volume status, pericardial abnormalities, T for the diagnosis and assess for the intracardiac thrombus, left ventricular outflow tract obstruction, right heart function, pulmonary embolus, pulmonary hypertension, cardiac shunt, pericardial and the cardiac tamponade, aortic atheroma and acute aortic syndrome. Next. Basic day examination include the 11 primary points, mid-esophageal 4-chamber, mid-esophageal 2-chamber. Next. Next. Mid-esophageal long axis, mid-esophageal ascending aorta long axis view. Next. Mid-esophageal ascending aortic short axis and mid-esophageal aortic valve short axis view. Mid-esophageal right ventricular inflow outflow view and the mid-esophageal bicaval view. Transgastric short axis view, descending aortic short axis view, and descending aortic long axis view. Comprehensive advanced T include the 17 views which help in diagnosis and ability to guide the perioperative decision making. Now coming to some case scenarios, 29-year male patient with the end-stage liver disease with portal hypertension, hepatic encephalopathy, jaundice and pruritus and holosystolic cardiac murmur. Patient received the post-clamp offer from 21-year-old brain-dead donor with the 40 to 50% of the fat. Intraoperative monitoring was include the arterial line, CVP and the T. Operation was performed, cable replacement, portal vein to portal vein and the recipient hepatic artery to the reconstructed donor hepatic artery. Next. Prior to the reperfusion, patient was on the higher dose of the epinephrine and required the multiple blood product and blood. Reperfusion multiple bolus at the time of the reperfusion, multiple boluses of the vasopressin and the epinephrine and the multiple fluid boluses required. At this time, allograft appears congested and enlarged. T probe inserted, showing the thrombus was noted in the hepatic vein, then in the IV, initially on the hepatic vein and then extend to the IVC. Modified transgastric hepatic vein views by rotating the probe clockwise from the transgastric view, omniplane angle 60 degree to find the long axis view of the hepatic vein. Next, please. Here you can see in the picture longitudinal liver with the IVC and the hepatic vein showing the thrombus. Actually, I cannot move my cursor, otherwise I can show. Here in right side figure also, it is a thrombus seen at the IVC and middle hepatic vein junction. Next. Alternating between the modified transgastric hepatic vein view and the modified bicaval view, IVC from the hepatic vein to the atriocaval junction can be visualized, which confirm the presence of the IVC suprahepatic anastomotic stenosis and the hepatic vein thrombus, resulting in the hepatic outflow obstruction, allograft congestion, and the hemodynamic instability. Surgical intervention include the IVC thrombectomy and the revision of the suprahepatic cable anastomosis resulted in subsequent allograft decompression. Patient recovered completely from the OLT. Next. Here you can see the picture. On left side, there is a transverse hepatic vein showing the minimal patency of the right hepatic vein. There is a very narrowed hepatic vein, and the another figure showing transverse hepatic vein showing partial patency of the left hepatic vein only, and color Doppler artifact is seen. Next. Here, suprahepatic IVC stenosis. You can well visualize suprahepatic stenosis and turbulent flow in the hepatic vein. And hepatic another figure, there is a hepatic vein stenosis, and here also IVC stenosis, turbulent flow you can see. And last figure, there is a thrombus in the RA IVC junction. So to get the lower esophageal hepatic view, primary diagnostic uses inferior ventricle vena cava collapsibility and the diameter, hepatic venous flow velocity, image setting, angle is 20 degree, and the probe adjustment rightward. In case of the transgastric modified hepatic vein view, 0 to 20 degree, and level lower esophageal manovier is from prior image, and continuous wave Doppler, and the advanced is as an advanced technology, and critical clinical utility like inferior vena cava, hepatic vein, inferior vena cava, diameter for the right atrium size we can visualize. Next. Another case, accidental laceration of the IVC during the left lobe of the liver resection surgery in 67-year female with the giant hepatic angioma with the required complement clamping and the re-established blood flow using the Edward bovine pericardial patch after declamping. T2 was done to check the patency of the IVC and the blood flow in the suprahepatic veins. Multiplan T is angle is able to identify three main hepatic veins, right, middle, and the left. Next. Usually, the normal hepatic waveforms has a four component a retrograde A wave due to the right atrial contraction, antegrade S wave, right ventricular systole, transitional V wave is a very small wave, pulmonary vein due to pulmonary vein closure, and antegrade D wave, right ventricular diastole. Flow above the baseline indicate flow towards the transducer, and the flow below the baseline indicate flow away from the transducer. And one should ask the four questions like is there any flow where it is that it is directed forward or the backward? What is the magnitude relationship between the S and D? Normally S is more than the D. And what is the magnitude of the A wave? Next. Here you can see the same what I said in my previous slide. Next. Another case during the OLTX, most dangerous phase is the reperfusion phase, in which surgical clamp is removed, leading to the sudden release of the cold acidotic oxidizing and the hyperkalamic fluid into the circulation, and lead to the reperfusion syndrome in 42% of the cases, and manifest as a temporary myocardial dysfunction with reduction in the heart rate, increase in the pulmonary arterial pressure, reduced cardiac venous return, preload, and decrease in the mean arterial pressure after load of the 30% cases. And here patients can have low preload and the afterload, and patient can have profound cardiovascular collapse. Next. If patient is having LVH and long anterior mitral leaflet, LVOT obstruction may occur. Management consists of the giving the fluid, increasing the afterload with giving some vasoactive vasopressor agents, and reducing the cardiac frequency. Next. Role of the T in lung transplant is my another point. Here, the indication for the T use in the lung transplant is only class 2B recommendation by the American Society of Echocardiography, and the absence of the guideline from the Society of Cardiovascular Anesthesiologists may explain its low rate of the adoption. Next. Lung transplantation is the definitive treatment for the end-stage lung disease refractory to the guideline-directed medical therapy. It is a complex surgery involving vascular anastomosis of the donor and the recipient pulmonary arteries, and anastomosis of the donor and pulmonary vein to the recipient left atrium. The patency of this delicate vascular anastomosis during and after the transplantation are critical to the survival of the lung allograft, and affect the patient morbidity and the mortality. Obstruction of the pulmonary artery anastomosis impedes blood flow into the lung allograft, which increases right ventricular afterload. This can lead to the pulmonary hypertension, RV dysfunction, hypotension, hypoxia, primary graft dysfunction, and eventually allograft failure and the death. Likewise, pulmonary vein cuff obstruction, which can develop as a result of the allograft torsion, the lung allograft recipient thorax size mismatch, and the anastomosis stenosis or the thrombosis also lead to the similar manifestation. In severe cases, both pulmonary artery and pulmonary vein cuff obstruction may necessitate the mechanical circulatory support. As a result of a high degree of the suspicion and the timely diagnosis of this condition in the intraoperative or the postoperative setting can prevent the hemodynamic decompensation, allograft failure, and the death. Next. Assessment of the RV. The RV is a thin-walled crescent-shaped, low-pressure, high-volume pump assessed by the geometry-dependent planimetry and the tricuspid annular plane systolic excursion, geometry-dependent, independent like Doppler echo, quantitative RV ejection fraction, and the qualitative septal curvature and the real-time visual assessment methods. Planimetry of the RV. Transverse plane long axis view and the transverse plane transgastric short axis view. At end diastole and the end systole cavity area traced manually by the automatic border detection or by the automatic border detection system and the RV fraction shortening calculator. Next. TAPSE, based on the concept of the most RV ejection is caused by the contraction in the long axis. Careful image acquisition is required to visualize RV pre-wall septal junction in both end diastole and the end systole. Maximum acceleration of the blood in the pulmonary artery also can be used as the index for the RV ejection. Next. In practical term, RV function measured qualitatively like RV end systole and end diastole areas assessed visually and ejection fraction is estimated. Interventricular septum visually assessed for the paradoxical curvature. Normally, septum bulges from the left to right due to the higher left-sided interventricular pressure. In acute RV dysfunction, septum bulges from right to left. Paradoxical septal shift occur in late diastole with the RV volume overload and in end systole and the early diastole with the RV pressure overload. Immediate post-transplant PVR decreases can cause or precipitate the RV outflow tract obstruction if patient is already having the severe RV hypertrophy. Increased PVR most commonly causes the RV failure and post-lung transplant period. Next. Tricuspid valve and the pulmonary valve assessed like antegrade ejection of the blood in the pulmonary artery depend on competency of the tricuspid and the pulmonary valve. Severe TR result in the overestimation of the RV function in normal ejection fraction with the severe RV dysfunction. Severity of the TR based on the ratio of the jet area to right atrial area and TR and the pulmonary insufficiency are frequently result of the PH. Doppler echo for the TR jet used to estimate the peak pulmonary artery systolic pressure and during the PR, a high velocity flow observed throughout the diastole in the RV outflow tract. Next. Next, yes. Severity of the tricuspid regurgitation, as I said, grade 1 to 4, less than 15% 1, less than 30% jet area is 2, 3 in less than 60%, and in 4, more than 60%. Next. Right ventricular function assessed by the internet atrial septum assessed by mid-esophageal bicaval view. Right ventricular function assessed by mid-esophageal four-chamber view, TAPSE in the transgastric long axis view and the transgastric short axis view. Pulmonary vein assessed in the four-chamber view by bicaval two-chamber view and in the left side left pulmonary vein and in the upper part of the LA it is the right pulmonary veins. In bicaval view also pulmonary right-sided pulmonary vein well visualized. Tricuspid valve mid-esophageal four-chamber view and modified bicaval view. Pulmonary artery upper esophageal view and the deep transgastric view long axis view and left ventricular again in the four-chamber view and the transgastric view. And other views are for the ECMO line, the mid-esophageal four-chamber view. Next. Postoperative hypoxia, obstruction to the normal pulmonary blood flow, and the intracardiac shunt, like in the ASD or the PFO, are major anatomic causes for the hypoxia. T can visualize the right pulmonary artery anastomosis in 100% cases and left anastomosis in 71% of the cases. In the upper esophageal view, colored flow mapping, yet suture lines can also be shown. Area of the turbulent flow, if is there turbulent narrowing is there, pulse wave Doppler can be performed above and below the suture line to measure the gradient across the anastomosis. Pulmonary venous connections are visualized by the T pulmonary vein diameter, color flow pattern, and the pulse wave Doppler profile. Diameter of the pulmonary vein and mean pulmonary venous velocity are greater in allograft than in the native lung. Next. Next, please. 2D and color flow mapping may show thrombus obstructing pulmonary venous blood flow from the allograft. Contrast echo by agitated saline is used to see the PFO. Next. And case scenario, patient posted for the bilateral lung transplant after successful right allograft. Patient developed severe PH and RV dysfunction and detected by the T. CPB was instituted and left lung implantation was completed. PH and RV dysfunction persisted, and again T done, which showed the right pulmonary artery anastomotic stricture. Right pulmonary artery anastomosis revised, and which corrected the PH. Temporary VA ECMO established for 24 hours.
Conclude.
Yes, ma'am. Here you can see the narrowing of the pulmonary artery. Next slide. And next slide. Image, I can show the image, just 2, 3. Here also you can see the RA-RV dilated and the suture line was narrowed. Next. Next. Next to next. Next to next. Here there was a mismatch in the thoracic cavity of the patient and recipient and the donor, and so that patient had congestion and went on the again patient taken in the OR and wage resection was done and then successfully went off. Next. 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 Next, last conclusion. Modified transgastric hepatic vein view and the lower esophageal hepatic vein flow, along with the other standard basic views of the diagnose and guide the real-time surgical management for the one lung orthotopic lung transplantation, ultimately leading to the graft preservation and the patient survival. T monitoring helpful during the lung transplantation for the hemodynamic monitoring and the vascular anastomosis assessment as a guide for the fluid resuscitation as well. Thank you.
Thank you, Jiaisha, Sachde, for that wonderful presentation on the role of TEE in organ transplant surgery. You dealt with the liver transplant and the lung transplant. Thank you so much for your contribution. Now, may I request Dr. Anita Shettv to share her slide. Dr. Anita Shettv.
She doesn't have the slides. You just do some.
Good evening, everybody. At the outset, I would like to thank the organizers of ICA and Dr. Sarkar for giving me this opportunity. My topic is role of TE in neurosurgery. Now, transesophageal echocardiography enhances the patient monitoring and helps us to reduce intraoperative adverse cardiac events such as venous air embolism and intraoperative cardiac dysfunction in high-risk patients. Now, as we have all seen that the images are collected by placing the probe at 4 depths, that is upper esophagus, mid esophagus, transgastric, and majority of the images are obtained. One second, I'll just minimize this. And deep transgastric, majority of the images are obtained at the mid-esophagus and transgastric level. Now, mid-esophageal views are mainly used to detect the presence of any intracardiac shunt and air. Transgastric views are meant to evaluate the ventricular function, and upper esophageal views can be used for patients with carotid stenosis and history of stroke. Now, in neurosurgical patients, there may be inadequate accessibility of the TE because of the close proximity of the surgical site and overlying surgical drape. Therefore, Gopal Krishna KN have designed a unique, simple, and universal method for placement of TE probe, which makes the probe manipulation and maneuvering easy with adequate retraction of the scalp flap. So what they have done is they've placed an L frame with the vertical limb of the frame placed firmly with the operating table, and the horizontal limb is placed 1 foot above the patient chest wall. Then the cranial drapes are placed over the horizontal limb of the frame with the aid of multiple towel clips. Again, there is a surgical screen is fixed with the L frame, and these are secured on the 2 stands placed on the either side of the operating table using towel clips. But the disadvantage is the proper retraction of the scalp flap and subsequent surgical dissection becomes difficult. So what they have done is the surgical colleagues have secured the towel clips which are attached to the retractor to the surgical drapes which are fixed to the L frame. Then the anesthesiologist from their side will take the towel clips and lock with the towel clip with the surgical towel clips. Then 1 more towel clip is attached to the anesthesiologist towel clip and it's fixed to the drape. So this will provide desirable. So what happened? Therefore, there is retraction can be done and maneuvering of the TE also becomes easy. Now, what are the indications for utilization of TE in neuroanesthesia? For screening of venous air embolism and paradoxical air embolism, identification of hemodynamic instability during the perioperative period, cardiac manifestations of intracranial hemorrhage, positioning of VA shunt and identification of the complications which are related to VA shunt, and positioning of the right atrial aspiration catheter. Now, how do we screen for venous air embolism? In 1980, Duff et al. Described detection of intracardiac air by using M-mode esophageal echocardiography. Though it is the most invasive, yet the most sensitive of all the available methods to detect air embolism. As little as 0.25 ml per kg of air can be detected by TE in comparison to 0.5 ml per kg as detected by precordial Doppler. So the American Society of Anesthesiologists and the Society of Cardiovascular Anesthesiologists Task Force on TE practice guidelines consider that TE is a class 1 indication to identify venous air embolism during the intraoperative period. Now, as we all know that sitting and semi-sitting position during neurosurgical procedures pose significant risk of air embolism, and therefore subsequently there can be central nervous dysfunction. The incidence of venous air embolism ranges from 1.6 to 76% in sitting and semi-sitting position. So when we use a TE, if you demonstrate air bubbles in the great veins and the cardiac chamber, that's a warning sign of venous air embolism. So once you know there is a suspicion of venous air embolism, the surgeon can take necessary steps to interrupt the surgical dissection, and quick closure of the venous system should take place. The 2 types of air embolism can be detected in TE. One is the single bubble type, which can happen during skin and muscle incision, craniotomy, and brain lesion excision. So if it is detected, electrocoagulation and application of bone wax can prevent further aggravation and embolism formation. The second type is the stormy bubble type, which can happen during dura and muscle incision. This can be prevented by electrocoagulation, reflection of the dura, and suturing of the affected muscles. Now, there is a grading for venous air embolism. It is graded from grade 0 to grade 5. Grade 0 is when there is no air bubbles visible on TE and no air embolism. Grade 1, air bubbles are visible and there is no change in EtCO2. Grade 2 is when air bubbles are visible and there is decrease in EtCO2 but less than or equal to 3 millimeters of mercury. Grade 3 is when air bubbles are visible on TE. There is decrease in EtCO2 is more than 3 millimeters of mercury. Then grade 4 is air bubbles are visible, decrease in EtCO2, decrease in mean arterial pressure more than 20%, and increase in heart rate by more than 40%. And grade 5 is when there are a lot of arrhythmias with hemodynamic instability necessitating cardiopulmonary resuscitation. Now, Faith et al. Reviewed 4,806 patients who were considered for neurosurgery in sitting position, and separately they reviewed 5,416 patients who underwent percutaneous PFO closure. And they saw that the overall rate of venous air embolism was 14 to 39%, and the rate of clinical and TE detected paradoxical air embolism was 0 to 14% in their series. And they recommend that screening of PFO and consider closure in cases in which the sitting position is the preferred neurosurgical technique. Now, how do you identify the presence of intracardiac shunt? So the PFO is present almost in 20% of human beings. There may be an anatomical PFO, but functionally it may not be seen. So what is done is agitated saline is injected into the central vein, and the right and the left atrial chambers are examined to detect patent foramen oval or interatrial shunt. Presence of PFO is demonstrated by visualization of saline microbubbles which cross from the right atrium to the left atrium. And this presence of patent foramen oval or atrial septal defect, you require a standard 2D TE view with emphasis on intraatrial septum from mid-esophageal, four-chamber, and bicaval view. So this is how you will see when you use the bubble contrast, where you inject an agitated saline through the central vein, you can demonstrate, and there is crossing over of the bubbles from the right side to the left side. Now, how do you place the TE probe in neurosurgical patient after the tube intubation? TE is inserted, and again the right and the left atrial chambers are examined under the effect of positive airway pressure to detect for PFO or interatrial shunt. Maintain at least 2 to 3 finger breadths between the inner margin of the chin and the suprasternal notch. After pinning and final positioning, a second study is done to confirm the optimal placement of the TE probe. Then the TE probe is locked in place and turned off, and it is again turned during craniotomy. Air entrainment in the right atrium is demonstrated by visualization of micro or macro bubbles in the RA, and you can also look in the left ventricle or the LA for the signs of paradoxical air embolism. So this is how it is demonstrated on TE. Now the most common, as I said, is the class 1 indication is for detection of venous air embolism. TE can also help us in verification of multi-orifice catheter placement. These catheters are placed in patients at high risk for venous air embolism. These catheters are placed with continuous electrocardiographic tracing and optimizing the position after the P wave deflection is noted. But TE can be used to guide the catheter placement. Mid-esophageal bicaval view is used to visualize the catheter tip at the superior vena cava and the right atrial junction. This is how you see the catheter tip. Now, TE can be also used for verification of ventricular atrial shunt. So it can be used for the placement and verification of the patency of the VA shunt. It was first introduced by Keller et al. For the patency of the VA shunt was determined by demonstration of an echogenic material around the tip of the atrial end of the catheter. In a case series of 16 patients with suspected VA shunt obstruction or for a placement of new shunt, the authors were able to perform the procedure under 5 minutes with no complication by using TE. Now, TE or routine echocardiography at regular intervals will also help us in diagnosing the complications of VA shunt, like thrombosis of intracardiac end of the catheter, thromboembolism, and tricuspid stenosis. Now, TE is also useful for identifying cardiovascular instability in the OR and ICU. Now, the manifestations of intracranial hemorrhage may vary from subtle electrocardiographic changes to myocardial infarction, congestive heart failure, ventricular dysfunction, and Takotsubo If the patient develops Takotsubo TE finding may have in TE, you may see low ejection fraction, akinesia of mid and apical segments of the left ventricle with or without a thrombus. Secondary to ventricular pleural shunt malfunction, there may be sometimes pericardial tamponade and heart failure. So TE will help us in showing the fluid collection in the pericardial space and the right ventricular collapse during diastole. As we all know, aneurysmal subarachnoid hemorrhage may manifest as ventricular dysfunction, hemodynamic instability, and pulmonary edema. TE may show chamber dilatation depending on the duration, regional wall motion abnormalities, global reduction in systolic function, and decrease in ejection fraction in these patients with subarachnoid hemorrhage. During spine surgery, when there is an acute blood loss, especially if the bleeding is occult into the abdomen or the retroperitoneum, TEE can help us in detecting cardiovascular collapse. As pulmonary TEE is a rapid bedside test, which is very sensitive and specific to detect pulmonary air embolism, especially when it happens in the OT or in the neurosurgical ICU. It's very uncommon to visualize the thrombus unless it's in the main pulmonary artery or the proximal aspects of right or left pulmonary artery, as the rest of the segments are usually not visualized by TEE. So the indirect way of identifying pulmonary embolism is identification of new onset of right ventricular dysfunction, volume overload of right ventricular, dilatation of the right atrium, functional tricuspid regurgitation, and increase in size of the vena cava, inferior vena cava. So to summarize, TEE is a useful tool to detect presence of PFO, occurrence of venous air embolism, or Takotsubo cardiomyopathy. It helps us in neurosurgical practice. It helps us in proper placement of central venous catheters and VA shunt, and refractory cases of hemodynamic instability, complications of VA shunt, or postoperative pulmonary thromboembolism can be detected early with TEE. Thank you.
Thank you very much, Dr. Anita Shettv. That was a very nicely presented overview of role of echocardiography, especially transesophageal echocardiography in neurosurgical settings. Very well done, and I'm happy that you mentioned about how to detect PFO, and you also mentioned that it might have to be closed if you are choosing to have a sitting posture neurosurgical procedure being done. Thank you so much for that. And we go on to the last presentation by Dr. Amarja Nagre. Can you please share your screen? Dr. Amarja Nagre is a leading cardiac anesthesiologist in Aurangabad, and she's well known for her educational and basically educational activities and her clinical skills. And she has her own website called www.cardiacanesthesia.in, where a lot of followers seeing that website on a regular basis. I have a great pleasure to welcome Dr. Amarja Nagre for us to have a talk on use of TEE in intensive care. Thank you so much, Dr. Amarja Nagre. Please start your presentation.
Thank you, authorities of the Indian College of Anesthesiologists and all the faculties here today. This is a very important topic, transesophageal echocardiography in intensive care unit. Transthoracic echocardiography has proven to be a part of great value, to be of great value in the critical care setting because of its portability, widespread availability, and instantaneous diagnostic capability. However, it requires a good acoustic window to allow accurate analysis. Transthoracic echocardiography has a high failure rate in those who are supported with positive end expiratory pressure, or in those with surgical incisions, limited mobilization, mechanical ventilation, or post-operative status who have dressings or drainage tubes on their chest or abdomen. Less hampered with these limitations, transesophageal echocardiography overcomes these problems and yields better quality images because the position of the probe is closer to the posterior aspect of the heart. According to Garcia et al., the use of TEE instead of or in addition to TEE not only provides new diagnostic information, but also influences major decisions. They found that over 70% of the TEE examinations confirmed the initial diagnosis, and the findings from TEE resulted in a change in clinical management in around 38% of patients, which is quite significant. TEE as a first or supplemental modality is deemed appropriate in the following clinical situations, like the non-diagnostic TTE, surveillance of LA thrombus or valvular vegetation for resolution on optimal treatment, or for modifying or stopping the therapy. Acute aortic syndrome, diagnosis of infective endocarditis, when with TTE, the probability is moderate to high. Evaluation of cryptogenic or suspected cardioembolic stroke. Patients with AF scheduled to undergo electrical cardioversion or radiofrequency ablation. Main implications are the suspected aortic dissection, suspected endocarditis, source of emboli assessment, and hemodynamic instability. In 2018, the Indian Academy of Echocardiography has published a practice guideline for the performance of TEE for evaluation of patients with suspected cardioembolic stroke. T is considered more sensitive for the detection of major cardiac sources of emboli such as LA thrombus, aortic atheroma, valve abnormalities, atrial septal abnormalities. Excuse me. Excuse me for a while.
I'm really sorry about this. If you would like to ask any questions in the topics covered so far, please feel free till Amarja settles down. She has come back. I think it should be fine now.
Sorry for that interruption.
No, not a problem. Not a problem.
He is considered more sensitive for the detection of major cardiac sources of emboli, such as LA thrombus, aortic atheroma, valve abnormalities, and atrial septal abnormalities. In a prospective multi-center cohort studies by Thomela et al., T showed a significant higher rate of treatment-relevant findings in cryptogenic stroke patient than TT. Adding TE to TT resulted in an absolute increase in treatment-relevant findings by 6.4%. Previous studies have also shown TE to be superior for the identification of cardiac embolic source, changing the treatment strategy in 16 to 30% of the patients. T in determining stroke etiology. While TE has been commonly used in younger patients to detect atrial septal defects, it has shown to be valuable also in older patients in determining stroke etiology and influencing the secondary prevention strategies. In cryptogenic stroke, T is essential to exclude right to left shunt across the patent foramen ovale. T is superior to transthoracic echo in management of patients of any age with TIA or stroke. This is something Sebastian et al. Has worked upon, and they concluded that T proved superior to TTE for identification of the cardiac embolic source in patients with TIA or stroke without pre-existent indication or contraindication for anticoagulation. In patients with normal TTE, a cardiac source of embolism was detected by TE in around 40% of patients independent of age. More than 1 of 8 patients of any age with normal TTE revealed a major cardiac risk factor on TE in whom anticoagulation was warranted. So aortic atheromas are a major source of this cardiac embolism, and here we can see a mobile atheroma, which is a grade 5 atheroma, which is very much hazardous and may cause this stroke, or this can embolize at any time. Now, coming to another important aspect is the TE of the LA appendage. In LA appendage is imaged in mediasophageal short axis view at 30 to 60 degrees and mediasophageal 2-chamber views at around 90 degrees. However, it is not enough to visualize the LA only in these 2 views, but as it has a complex 3D anatomy. So we have to keep the LA in center, and we have to scan from 30 degrees to 135 degrees as a whole. And if you find such a clot in LA appendage, we have to proceed with the anticoagulation therapy, which is usually done in the ICUs. TT, many a times TT has this problem of poor window, and this is a case of LV thrombus. Yes, but we cannot delineate because of the poor window. So your transesophageal echocardiography can come very handy, and this is the short axis of the LV, and here is the LV thrombus, which can be delineated properly in case of TEE. This thrombus exclusion is very important in patients with AF as well, scheduled to undergo electrical cardioversion. At least 15% of all strokes are cardioembolic in origin. LA appendage is the commonest source of embolism in the presence of atrial fibrillation, mitral valve disease, or both. Anticoagulation, surgical LAA occlusion during mitral valve surgery, or percutaneous LA appendage exclusion can be done accordingly. The sensitivity and the specificity of TE for diagnosing these LA appendage thrombus has been reported to be as high as 100% to 99% respectively. Now, next is the infective endocarditis. Many patients who land up into ICU after their valve surgeries or due to their valve diseases are suspected to have infective endocarditis to mainly cause their symptoms and signs. In patients who have this high clinical suspicion, especially if the TTE is negative, TE is the modality of choice. TE has higher resolution to diagnose even the smaller vegetations. There is generally a low threshold to perform this TE in these patients with suspected prosthetic valve conduits or pacemaker endocarditis as well. In acutely ill patients also, we should have a low threshold to perform TE to pick up early palpebral abscess, valve perforations, prosthetic valve dehiscence, or any other structural damage caused by infection. Also, surveillance TE is indicated in infective endocarditis if there is no response to treatment or deterioration of the clinical condition occurs. This vegetation is a big vegetation seen on the tricuspid valve here, and which can be easily picked up by the transthoracic as well as transesophageal. But the smaller vegetations like this one on the mitral valve needs transesophageal echocardiography for accurate diagnosis. Now, next is in the ICUs, we find hemodynamically unstable patients a lot many times. In these patients, especially if they are post-MI or post-operative patients, as in cardiac ICUs, T is indicated when the cardiac cause of deterioration is suspected, and TT is either non-diagnostic or not feasible due to chest drains and dressings. T is usually done in these patients to recognize new onset or worsening LV diastolic dysfunction, aortic dissection, LA thrombus, ruptured papillary muscle, cardiac or aortic source of embolism, intracardiac vegetation, acute native or prosthetic valve dysfunction, and these are usually missed on TT, and hence T is recommended in these patients. Another patients, if you are suspecting that this patient might embolize, there is LV thrombus or something, and if they have a shunt and you want a patient to be posted for device or something, you can always go for TE for better, because ASD rims, especially the SVC, IVC rims, are transthoracic. Aortic rim. These are better assessed with transthoracic, and usually they are better assessed with transesophageal, and usually transesophageal is done before the patient is posted for device or surgery. Then TE is very important in aortic dissection cases. There is high accuracy of TE in diagnosis of aortic dissection, and the reported sensitivities and specificities are around or above 90%. This is a case of aortic dissection. IVC measurement for IVC for volume assessment. The newest guidelines from the AAC tell us that the IVC assessment has to be done. This is the TE of the IVC, and this is the hepatic vein, and the RA, this is a collapse because our patient was CABG was going on, and the RA and RV is compressed. That is why it is seen like this. Then also you can use TE as an aid in cardiopulmonary resuscitation in cardiac arrest patients. They have been shown to be helpful in identifying the presence or absence of intrinsic cardiac contraction and distinguishing the pulseless electrical activity from the true asystole. It helps in dynamic evaluation of effectiveness of chest compressions as well. In as many as 20% of cases, it can identify the cause of arrest such as severe hypovolemia, cardiac tamponade, massive pulmonary embolism, aortic dissection, or myocardial rupture. Mainly the 6 views are of importance in CPR-TE protocol. It is the midsurgical 4-chamber, 2-chamber long axis, bicaval, transgastric short axis, and the descending aortic views. Only the problem is you have to be very careful because the cardiac massage is being given, esophageal or gastric rupture can occur in these patients. Now, another important is many times in the intensive care units, IIBP is been put, and TE assessment before IBP is put to exclude a significant AR, aortic dissection or aneurysm is very important because these are the contraindications for IBP insertion. Then the guide wires are confirmed in the descending aorta, and aortic views are very much useful for IIBP. These are the guide wires seen here. The IBP tip is also seen, and the guide wire is seen in the descending aorta. Another point is the point of care ultrasound, that is POCUS. Transthoracic POCUS is routinely done and is very popular nowadays. Transesophageal POCUS is still a progressing field. POCUS TE has 5 essential views: the 4-chamber esophageal 4-chamber view, the short axis view of the aortic wall, the two-chamber view, the long axis view of the mid-esophagus, and the mid-esophageal bicable views. Focus TE can be invaluable in such situations, targeting ventricular size of function, volume status, status of pericardial effusion, or guiding pacemakers, cannulations, and other procedures. Focus TE can also be demonstrated of much utility in CPR. Lastly, T in ECMO. T is essential to guide and confirm the cannula positions both in VA and VV ECMO, which is usually done in the ICUs or the cardiac ICUs. Incorrect placement of cannulae can cause inadequate blood flow and recirculation. Therefore, guidance under TE and their placement and positioning is very, very important. To ensure the proper functioning of ECMO, T is also of importance. We have to note that LV dilatation doesn't occur, which indicates inadequate drainage of blood flow. Also, see that hepatic vein flow and velocities are normal because congestion of hepatic veins may occur due to malpositioning of the cannula. Also, you can rule out the thrombosis, that is an ECMO complication with TE. That was all from my side today for TE in ICU. And thank you so much for having me here for ICA webinar. Thank you.
Thank you, Dr. Amarja, for that excellent presentation on use of echocardiography, especially transesophageal echocardiography in intensive care units. You highlighted several important areas where TE is helpful. For example, thrombus, the IVC diameter, aortic dissection, IABP, CPR, focus, and ECMO. So many points are covered. Thank you so much for that.
Thank you.
And Dr. Manjula Sarkar, you want to do the discussion?
I think all the speakers have really done the good job and the points were covered. And my is really surprised that can be used in so many cases and so many patient centers, so many branches of the season concern, starting from surgery or surgery, onco surgery. And I'm sure sir, that your next lecture of TE for cardiac surgery is going to be beneficial for your students in the next session, which we are planning to do it. And it's really great webinar on the way for TE for cardiac procedures and such. And sir, you can conclude now as we are finishing the time also. I can't see any question on the chat box. So if you want to ask anything from any of the panelists, you are most welcome, or any other person wants to know from each other, then most welcome.
Couldn't make out what you're saying. On behalf of Indian College of Anesthesiologists, I would like to thank Dr. Manjula Sarkar for arranging this wonderful seminar on the use of transesophageal echocardiography in non-cardiac settings, especially non-cardiac surgery and intensive care units. The speakers have done very well. Dr. Sanjeeta Umbarkar mentioned that cardiovascular disease is a leading cause of death in pregnancy, which is absolutely true. And Dr. Nandi mentioned about the use of TE in onco surgery. Dr. Neeti Makhija highlighted that even anesthesiologists and intensivists not practicing cardiac should receive basic TE training. That's very aptly said. I really appreciate that statement. Dr. Jiaisha mentioned the role of TE in organ transplantation, especially in liver and lung transplantation. Thank you very much. I did like the presentation by Anita Shettv. She mentioned about the novel technique, how to use TE in neurosurgery. It's very important point which has to be noted, and how to deal with PFO if you see, and if you need a sitting position craniotomy, what to do. And ultimately, we had Dr. Amarja Nagre telling us about the role of TE in intensive care settings, and all the speakers have done wonderfully well. Thank you for adding to our knowledge about the role of TE in non-cardiac settings and intensive care settings. Is Dr. Radhakrishnan available to say a few words, or anybody else?
Well, Dr.
Yeah, Dr. Balji, there's.
Yeah, well, I was listening very patiently to all the topics. I think all of you have done a great job. As you already mentioned, Dr. Manjula, of course, to start with the introduction, then Dr. Sangeeta, Dr. Rudranil, Dr. Neeti, Dr. Jiaisha, Anita, Shettv, and Amarja Nagre, despite the fact that she was having tough again. But despite that discomfort, she did a wonderful job. All the speakers have done a great job. And I think TE has, it has a lot of implications, well-established place in cardiac, procedures, cardiac field. It's coming more out of the cardiac OTs to different other applications, as all these speakers have highlighted so very well, whether it is neurosurgery or it is trauma or it is transplant or even for general surgery. So it has a lot of application. And I sincerely believe that in the coming years, we'll hear more and more of TE application in various other fields as well. It's already very late, so I'm not going to take much time. And I, on behalf of Indian College of Anesthesiologists, thank all the speakers once again. And of course, to the moderators for a wonderfully conducted program. So from ICA now, good night to everyone. Thanks again, all the speakers for the excellent talks, and of course, the participants.
Thank you very much. Thank you so much.
Thank you, Sanish.
Thank you.
Good, sir. Safe is the backbone.
Thank you so much.
Because part of so
Thank
you so much, everyone. As with all your permission, we are closing here. Till then, take care of yourself, everyone. Hope to see you again with different topic and on Wednesday, 7 p.m. And we are closing here. Thank you so much. Good night, everyone.
Thank you very much. Good night.
Welcome, sir.